Broadcast is now starting. All attendees are in listen-only mode.
Sir, you can even start the webcam for a few minutes.
चालू होगा ना?
Okay. Well, friends, welcome to today's webinar, and we have with us Dr. Arun Jamkar. He must be known to many of you, and he is a ex Vice Chancellor of Maharashtra University of Health Sciences, and you must have heard him in many conferences, and I have known him for many years. He is a famous fellow, a faculty there, a very president of the National Association of Indian Association of Vice Chancellors of Health Universities, and also he is currently working at the MIT group of medical colleges in Pune, and he is a consultant with the Persistence Systems Private Limited, and also the National Chair of Bioethics Implementation and UNESCO Chair of Bioethics, and also he is the consultant to Palash Healthcare and Seed Infotech, and also the Chief Medical College Officer in the Index Technologies in USA, and Brand Ambassador of British Association of Physicians of Indian Origin. And besides this, in last 7-8 years, I have seen him in decision-making role in many activities at MCI level, at university level in Maharashtra, medical education scene. I mean, the list, if we start, it is going to be endless. Over to you, sir.
So shall I close the video?
Yes. Yes.
Okay.
Yes.
Good evening, Professor.
Make the screen full screen, sir. Please, slideshow. Press on slideshow. Yes.
Is it seen now?
Yes, sir.
Okay. Good evening, professors. Let me first thank Dr. Sanjay Bedi for inviting me to talk on this very interesting topic. It was a very innovative idea of Sanjay to train people in designing questions. Today's day, the teachers need to be trained in designing questions. We have applied technology. MCQs are everywhere, but the limitations of MCQs everybody knows. And whatever MCQs we see, if you see the National NAB website, all our MCQs are shown as what we call as graveyard area. The problem with today's education is students are very intelligent. They have acquired the new technology. At the same time, teachers were not trained because teachers were from the extra generation. So at this background, I must thank Sanjay for creating this innovative webinar series, and I have attended almost all of them, and I have found out how interesting it is. The basic theme of my today's talk is constructing scenario-based multiple choice questions. Now this is me. I was Vice Chancellor of an MUHS, the state-owned University of Maharashtra. But my contribution, apart from what Sanjay has kindly described, is I was the member of Dr. Roy Chaudhary committee. Subsequently, all those committees which has came into National Medical Commission bill, and I'm proud that the National Medical Commission bill has been sanctioned. And now, as a teacher, as a medical teacher, we have a lot of more responsibilities to make better medical education in the country. And better medical education would mean better evaluation, better training. And I'm very happy, the MEU group, it has more than 20 to 30,000 teachers, and it is so resourceful that you put anything there, the answer comes very fast. After my retirement, because I was interested in technology, I took persistent systems, and I am the technical advisor of the persistent systems. It's a software giant. Just to add my story, we are creating one drug dispensing ATM which works on symptom-based algorithm. So smaller problems that we routinely encounter, which could be handled beyond little OTC drugs, can be handled, and it can solve rural health problems. I am the director of postgraduate of MIT Group, where I work as director. In addition, I had recently an appointment with Index Technology, where we are trying to utilize NGS technology for a better cancer care. Today, I just going to identify what are the components, explain the strength, maybe it might be little repetition, and justify as analytical method of scenarios. And I will try to give input how to construct scenarios. To begin with, I just want to introduce that as a university, we were taking a lot of baby steps in creating scenario-based education. All our MCQs, they are recall basis, and because they are sometimes so easy that the creative talent, decision making, and other faculties that required for one to become a doctor are not there. So I was, after all my professors in MEHS, to start scenario-based question papers. Only problem is a question of faculty development. So to begin with, we thought let us do with postgraduate. And MEHS curriculum, which was sanctioned by academic council, that the 50% questions should be scenario based. Because unless you have scenario based question papers, you can't judge how a doctor is going to treat the patient. Obviously, there was a lot of resistance, and therefore it went too slow, and after my tenure is over, I don't know whether they follow. I met Dr. Vinod Paul several times, and he was also not happy about the contents and the quality of MCQs, what happens with NEET or what happens with NEXT. And therefore, he was very much interested that all faculties of India, they put their mind and get trained in scenario-based question papers. Scenario-based MCQs have various forms, but then after my meeting with Dr. Vinod Paul, I put a request to MEU group, and there are more than 25 to 30 professors who were trained in scenario-based question papers, and I thought we can give input for how will you have your next, say, National Medical Commission Declaration exam. Now, the scenario-based question paper for NEET would be little difficult, and it can be used only for postgraduates, because the NEET exam is for undergraduates, where the curriculum is biochemistry, anatomy is not there. It's all basic sciences of 12th standard. So there it might be little difficult to have scenario based, but then for postgraduate exams and undergraduate exams, we need to have scenario based question papers. We need to have scenario based even in basic sciences, anatomy, physiology, pharmacology, and I'm going to deal with that. So quality of multiple items are difficult to construct. The more experienced you are, the more you learn how hard it is to create fair and accurate questions. So the moment we become senior, I think construction of these MCQs becomes more and more difficult. And if you see what is education, actually education starts from what you call as what you don't know. Because there is a famous saying, the one who knows not that knows not that knows not. He's a student, so study him. So I think in same basis, education is learning what you didn't even know, what you didn't know. And I think today's scenario is such that all professors, students,
Yes.
Please mute your microphone so that we don't have much of noise. So education is learning what you didn't know. I think we all know about components of MCQ. We have stem, we have correct response, and distractor. Now, in a scenario-based thing, the stem would be different, and that's why we need to have the stem in such a way that we have correct response, just reading in one go, and distractor has to be, say, made in nicely. Now, what is important to understand is the Bloom's taxonomy, which we use, is need to be modified, and we need to look at the new Bloom's taxonomy. Earlier, we were calling it knowledge, application, analysis, synthesis, and evaluation. Now, we have to understand that the knowledge goes into the same phases: remembering, understanding, applying, analyzing, evaluating, and creating. So these taxonomy need to be seen so that what we need to do now is all your question papers need to address these domains. We should have remembering, understanding, applying, analyzing, evaluating, creating. And the question papers of the MCQ questions need to direct towards that. So what is important? So this revised taxonomy need to be described. Remembering is recalling information, recognizing, listing, describing, reading, and finding. But then it goes into understanding. Understanding is explaining the ideas or concepts, interpreting, summarizing, paraphrasing. Okay. So what is next is the student need to apply this information for implementing, carrying out in execution. And then it goes into analyzing, breaking information into parts to explore understanding and relationship, and comparing, organizing, reconstructing, interrogating, and finding. Then it goes to evaluation, where the decision making comes, the justifying a decision, the checking, hypothesizing, criticizing, experimenting, and judging. And at the end, what we want from postgraduate or undergraduate is generating new ideas, products, ways of viewing things, designing, constructing, planning, inventing. So I think this is the process of revised taxonomy by Bloom, and as I rightly said, we need to have all our examination in that way. So I'm just going to go through the cognitive domain, level 1. It is just a remembering. These are the questions. I'm just flashing out. Understanding. Understanding would mean a simple question like this. Comprehension is level 2. Applying. So application. So small questions like this need to be where he can apply. And if you make it, if you see this, there is too much of long stem, and the application was little indeed very difficult. So if you revise, these are the revised example of application. Now I'm going to put all those slides because I have to complete in 1 hour. So these slides will be there. Then analyzing. So analyzing, this level requires knowledge comprehension, and this is an example of an MCQ. Evaluating. Evaluate is a creative process, and therefore after evaluation we should be able to judge whether it is excellent, good, mediocre, or unexpected. Evaluation is a classical example, but I think we need to evaluate the examples. The example is too long. And synthesis is another example. So this is about the levels that we have, and then how each MCQ that I have shown has addressed these domains. So while you construct an MCQ, you need to understand whether it is for formative or summative, what is intended learning outcome, how will students complete the test, how will the test be marked, and are students used for MCQ format. So as a professor, we need to have a detailed subject knowledge, learning role, and target group, because an MCQ maybe scenario based would be different for undergraduate, postgraduate, and super specialty. So I'm just repeating, this whole thing is already been covered, but then I'm just flashing the slides to see that these are the some of the things which we need to follow. So writing stems, writing options, and ongoing. So MCQ writing guidelines, content, style, stem, and then checklist for formulation of MCQ. I think this whole thing has been already covered. I'm just trying to repeat so that I am able to give a background for scenario based. Now, there are a lot of these qualities of the stem, because the stem in a scenario based is all scenes, actual real patients, and options are operations or scenes, and these are the keys. So content concern should reflect single content, important non-trivial content, use novel material, keep atom independent, avoid opinion-based atoms, avoid trick atoms. So trick atom is something a very trivial content, it's too difficult, discrimination, multiple correct answer. These are all trick atoms. So ammunition for students who did poorly on this test. So central ideas, I think what is required to understand that while any MCQ is created, the quality of distractor has to be there, and you require a lot of intelligence and your experience for distractors. So specific directions, design for the important knowledge. Okay, avoid, I'm just giving you a flashback, avoid questionable interpretations, avoid asking two questions at the same time, state problem clearly, simply, and as correctly as possible. State problem, this is a revision of earlier slide. State problem clearly, this is improved question. So which one of the following statements are true? Keep reading to minimum, so that the stem has to be small. So if you see, this was a long question, and it was almost 5 lines, and therefore in improved question the stem has been reduced, and place common elements in the stem. Place, this is how it is placed. So improved question would be this way: the hyperplasia is defined as a change resulting from increase. So avoid stereotype phraseology, as rote response is usually based on verbal stereotypes, and the stem may be written as direct question. Avoid including non-functional words. These are 8 essential amides, one of them. So improved question is which one? Directly. Avoid unnecessary and irrelevant material. So this is improved. So I think with this background, now I'll come that the background material for designing MCQ is now there. So with this background, how will you design a scenario-based question paper? Now, a scenario-based question paper starts from a clinical details. Now, these details need to be given in complete knowledge. So anywhere, its scenario should start from name of patient or age, gender, site of care, where the patient is being treated by emergency department, what is the presenting complaint, duration of complaint, then give patient history. Sorry, I just closed the window. So including past medical history, family history, psychological history, review of system. So this whole thing need to be given as needed in a scenario. Physical findings, results of diagnostic studies, initial treatment, subsequent findings. So what is important is constructing a scenario. The clinical details, as if you are treating a patient, need to be given. Now, while you give clinical details, you need to understand that we need to focus on concepts rather than trivial facts. The stream of clinical material has to be created in such a way that it can be answered without looking at the options. It should include all relevant facts. No additional data should be provided in the option, so that the stream has to be complete. Nothing in options. So otherwise, it goes into waste. And it not be tricky or overtly complex, because if it's too complex, then the distraction becomes heavy, and it should not be negatively phrased. I think this applies to all of them, that no double negative and negative. Now, the challenge is to create these scenarios, and the best way is to use a real patient. That just take a patient, examination findings, all those findings need to be given detail, and then the diagnosis or treatment protocol or any question identified need to be given first. And once it is given, it requires an intellectual reconstruction to give the distractors, because this most important is the distractor, otherwise it becomes too easy. So I think the first hint that I want is using real patient. As a general rule, real patients are complicated. They might have multiple problems. So what is required is to suitably extract only the positive findings pertaining to a particular diagnosis or an answer. If it is too complicated in a real patient, that need to be modified. So if it is too complicated, then it becomes very difficult for assignment. It is fine to sometimes include window dressing, such as incidental finding. So maybe sometimes you have to give a facelift to these items by putting some material which may not be there in that patient, but it is going to help for the answer. Now, I'll give one example of a real patient. A 52-year-old woman comes to the emergency department. So it has been shown that where it is coming, age is there, of 1 week history of a low-grade fever. So the duration of history, increasing abdominal cramp and exacerbation of the bowel movement. She began a course of amoxicillin, clavulanate, and metronidazole 2 days ago. So treatment protocol is given, and had no relief of the symptom. She has had intermittent constipation, so another symptom for last 12 years. She had no nausea, vomiting, urinary symptom, or bloody stools. She has a 3-year history of hypertension. She underwent a total abdominal hysterectomy and bilateral sulfing oophorectomy. So history of operation because of leiomyoma. So everything is given. So then particulars: she is 165 centimeter tall, weight, BMI, temperature, pulse, BP. Everything is there. The lungs are clear. Cardiac examination shows no abnormality. Abdomen is soft. There is tenderness to palpation of the lower quadrant without guarding and rebound. So bowel sounds are normal. The stool is brown. the platelet count is there, and now with all these details of the patient, this is a real patient. Now, what is required to be done further? And if you see the choices are so much like that they are perfect distractor. Obviously, this patient requires a CT scan for the abdomen with contrast. But then everything is there. Now, somebody will say, why not colonoscopy? But colonoscopy is not required. So I think this is an ideal example of a real patient history giving you distraction. Now, other thing which you can have is sequential answers. So we give history, and then now this is a history. If you can see, it's a perfect history. Age is there, a 35-year-old woman brought to emergency department, worsening patient, and then she has no history of trauma of the knee. She otherwise healthy. She is extremely active and has 10-year-old son who lives. She is receptionist. So everything is there. And at the end, X-ray of the knee shows an effusion, but no structural abnormalities of the joint. Which one of the following is most appropriate next step? Obviously, there is a fluid inside, so it requires an orthocentesis. So just looking at the stem, the treatment protocol or what is further is seen. Now, if it's a sequential, then what happens is now orthocentesis is done. The synovial fluid is cloudy. The gram stain is negative. Analysis of the synovial fluid shows a leukocyte count of 120,000. Obviously, we need to find out it is sterile or not. So following investigation would be a culture. So there is no question of measuring proteins or polarization, but then protein is a nice distractor. Glucose measurement is nice distractor. I think so. Here, what we have done is sequential questions. So this is something called as EMQ, extended matching questions. We can have 4 or 5 extended matching questions depending on your requirement. Now, most of the time, I'm just going to insist that even the clinical scenarios should be used in basic sciences, because people tend to find out and then to say reject the idea that the clinical scenarios are not required in basic sciences. But then I think basic sciences also, if the scenarios are there in examination, they shouldn't tend to correlate your basic sciences with the clinical. Now let us say histology. Now 42-year-old man was found to have an unexplained abnormality of his liver function test. He underwent a liver biopsy that was reported as normal. So what cell type is most likely involved? So the giving and stem of an history and then pertaining to the histological finding. So the clinical science, basic science could be there. Anatomy. Now even anatomy, you can have clinical scenario because giving clinical information about an operation. Now this is a nice example. 60-year-old man underwent a laparotomy for abdominal pain. He was found to have a gastric tumor eroding through the posterior wall. And now we need to create intellectually all the organs around because I didn't put it there. So what are the adjacent organs most likely affected? So this not only gives anatomy, at the same time the student will understand and find out how the tumor spreads. And so both facility of a spread of tumor as well as anatomy will come into picture to answer this, say, scenario-based question. Now the 19-year-old man reported numbness over the dorsolateral hand after being stabbed in the lateral aspect of the right upper arm. So this is a nice scene, and this is a trauma. And therefore, what nerve affected gives entirely a clinical scene pertaining to anatomy. Physiology. 25-year-old woman developed a chronic renal failure from glomerulonephritis. The doctor inferred that damage to the kidneys, proximal coronary tubule, and has impaired particular function of the kidney. So which function? So I think this, even a physiology question, is addressed towards a scene. Clinical pharmacology. A 60-year-old man was taking regular medication for congestive heart failure. The doctor identified this drug as phosphodiesterase. inhibitor, which prevents the inactivation of intracellular second messenger in the cardiac myocyte. So what is the most likely identity of the second messenger? So I think this gives an entire clue, and then a clinical scene can judge the pharmacology knowledge. Even microbiology questions could be done in similar way. A 32-year-old man developed a plasmodium malaria infection after visiting the Gambia. He hadn't taken appropriate precautions and so asked how the infection could have occurred. The doctor used a diagram of the organism life cycle to explain this, including the stage of development of the time of the transmission of the mosquito. So it is asking you what stage of the organism's life cycle did the doctor most likely to highlight. So giving a clinical picture, and we need to know both clinical picture as well as the development of mosquitoes and development of whole thing. So this explains the life cycle as well as both things are coming. At the same time, I just want to find out and suggest that our zeal should not create redundant scenarios. Now, this was one of the scenario. A 32-year-old man, generalized weakness, had a biopsy taken from his quadriceps muscle, which was examined using electron microscopy. The pathologist reported an abnormal appearance of Golgi apparatus. And what is the main role of Golgi apparatus? And then there are 5 roles are given. Now, obviously, if you see the stain, the first component of clinical examination has nothing to do, because what is the main role is the question. I think that's why this becomes a redundant scenario, and therefore same scenario if you could modify. A 32-year-old man with generalized weakness and underwent a muscle biopsy and that identified an abnormality of Golgi apparatus. So instead you ask what cellular function was most likely to be abnormal. So I think instead we are modifying a redundant clinical scenario into a scenario which is identifiable. Now we can have image-based scenarios, video-based scenarios, and clinical skill evaluation. Now this is taken from USMLE, and it is very obvious. There's an image. At the same time, you can't diagnose just with image. So whole history is given, age is given, current medication is given, and then the X-ray is shown. Obviously, in this X-ray there is a huge pneumothorax with a collapse, and this is atelectasis. But then image can be used for identifying the diagnosis. Now this is another image examination. I have taken it from USMLE step 1. A 56-year-old man had a painful weeping and rash around 2 days. He underwent chemotherapy for non-Hodgkin lymphoma. So his background is given, and his temperature is 36, so he is normal, pulse is normal, blood pressure is normal, and there are no abnormalities. And because he is already on chemotherapy, so we need to find out that he is getting, now if you can see here, he's all along the nerves. So this is herpes zoster. But then if you can see the distractors are almost addressing same thing. So in showing an image, we can even have choice of therapy. Now here a 67-year-old woman comes to the physician, and 1 month after noticing a non-tender nodule on the back of the left hand. She initially thought it was an insect bite, but it grown in size. It bleeds when she picks it up. She has no history of serious illness. She lives in retirement community in Florida and frequently plays golf and tennis. Examination of the dorsum of left hand shows 2.5 centimeter lesion. The photograph is shown. So obviously this requires to be removed, and the best choice would be a cryosurgery. Now we talk of competencies, and I think all these competencies that we are going to apply need to be used for evaluation, and these scenarios need to be created in such a way that we address these competencies. So let us say now competency, we want to find out medical knowledge and scientific concept. applying foundation science concept to the content area, and then it's about cardiovascular system. You can read. I'll just take a sip of water till then. So this is a nice history. 55-year-old man had a crushing substernal chest pain on exertion over the past 6 weeks. He had a myocardial infarct 2 months ago. He takes nitroglycerin as needed and 1 aspirin daily. He has smoked 2 packs of cigarette daily for 30 years. Examination showed normal heart sounds and no carotid or femoral bleeding. So treatment with the beta-adrenergic blocking agent is most likely to improve his symptoms due to which of the following mechanisms. So obviously we need to understand now this is giving you STAIN, which is the cognitive knowledge, scientific content, and then beta-adrenergic blocker. Now if you see the distractors, they are so alike that we need to just find out and know what beta-adrenergic blocking agent really does. Obviously it uses the by decreasing myocardial contractility, but then everybody should aware that what are the other effects. So this is one competency of area of a cardiovascular system and medical knowledge. Now other competency, patient care, management, pharmacotherapy, content area is hematopoietic and lymphoreticular system, and what they are finding out is adverse effect of the drug. Now if you see this STAIN, a 55-year-old woman, age, small cell carcinoma, admitted to the hospital undergoing chemotherapy. 6 days after treatment, she develops temperature. Physical examination shows no abnormalities. Laboratory studies show that leukocyte count is only 100. 5% segment neutrophil. Which of the following is most appropriate treatment? So now with this background that there is a chemotherapy already given and the WBC count has gone down, all those distractors are same, but then the filgrastim has to be used to improve the WBC count. Now this is obviously taken from USMLE. We may not be using it here now. Now other competencies like even professionalism can be judged with scenario-based questions. Now this is a nice question which I like. A 45-year-old man comes to the physician for HIV testing. He says that he has been having an extramarital affair with a woman for 6 months, and he hopes this affair will continue because it has made him very happy. He has no plans to tell his wife. The wife is also a patient of the physician. So ethical problems. Physical examination shows no abnormalities and the result of the serum HIV antibody test is negative. So which is the most appropriate action for the physician? Obviously, all these are showing you all distractors which pertains to ethics as well as professionalism. And therefore, obviously, both are patients, but you have a professional duty, professional obligation to the patient. Therefore, the choice is D, that say nothing about the affair to anyone other than patient, because patient has confided in you. You can have competency, patient care, clinical intervention, female reproductive tract. So I think if you're going to use scenario based for our next, we need to chart all of those competencies from beginning, and we need to address all of them directed towards, and there has to be distribution like in USMLE. Previously healthy 27-year-old Nelly Gravida comes to emergency department because of 2 days history of moderate to severe pain and swelling of the left labia. She is sexually active and uses condom inconsistently. Her temperature is 37.2. Respiration, everything is normal. And what is important is a very nice sign given. Pelvic examination shows 4 by 3 centimeter tender fluctuant mass medial to the left labia majora comprising of intra-aortic opening. So obviously this is a nice description of an abscess, and so there is no use in giving IV metronidazole or IV penicillin or ultrasound guided needle. So what is required is incision drainage. So even the the clinical intervention can be judged with giving you scenarios. Now, the competency-based scenarios are used everywhere in USMLE, MRCP, even Australian medical examination. And therefore, I'm just going to show you live what are they. And let us go one by one. This is USMLE site. Now this is step 1. I think everybody is aware. Step 1, step 2, step 3, step 2 CS, step 3 CS, and then the content description. So if you see the sample items, now this is step 1, this is step 2, and this is step 3. And in step 3, they use videos, and this is explaining you the videos.
First, I want to order CBC, which I could also type as complete blood count, USMLE Step 3 exam. What is a CCS case?
Now,
Well,
what is it?
It's a dynamic and interactive clinical scenario where you're responsible for the
Are you able to
patient's care.
listen?
In the
the
Step
video?
3 exam, you will see a series of CCS cases, which are designed to evaluate your clinical judgment.
Yes, sir, we
and
can
medical
listen.
management. Most likely,
Because I thought the voice of the video has to be
before. We hope this video prepares you to navigate Primum so you can comfortably manage each case on the exam. Throughout this video, we will be referencing the Primum CCS frequently asked questions, or FAQs, available on usmle.org under the practice materials for Step 3 CCS. To begin,
For next, I
let's
think
go
we
over
should
the
need to
concept of
create
time
similar
related to
platforms
managing a
like
CCS
Primum.
case. On CCS, there's
And
real
then,
time.
and then this is a real-time management of a patient.
Real time is the literal amount of time you have to complete each case. You will be shown the maximum allotted real time you have before each case starts. The amount varies for each case, and a certain portion of that amount of time is reserved for any case-ending actions. It is also important to know that depending on your actions in a given case, you might not need the full amount of maximum allotted real time. Now, simulated time is time that elapses during the clinical simulation for one patient. In simulated time, some cases last for weeks, others for days, some just for a few hours. For example, you can complete a CCS case in, let's say, 11 minutes of real time, but manage the patient in that case over the course of 2 weeks in simulated time. At the end of this video, we will review the concepts of real and simulated time. Now, let's walk through a case together. First, you will see the case start screen, which shows you your maximum allotted real time. Click Start Case to launch the Primum software and manage your patient. Now that Primum has launched, let's take a look at the top of the screen. You will see that this case begins in simulated time on Monday at 11 a.m. At this time, feel free to adjust your reverse color or increase font settings. These controls can be found in the upper right-hand corner of your screen and can be adjusted as often as you'd like and at any time in the case. Now, let's read the introduction of this office case. Click OK when you are done reading. Primum will move to the next screen. Next, you are presented with the patient's vital signs. When you're done reviewing this information, click OK to review the initial history. It's important to note that we can't ask the patient any questions. However, be reassured, CCS case writers take this into consideration and provide all the relevant information you will need. Now, you are able to manage your patient. I'd like to start by clicking on the Write Orders or Review Chart tab to refresh my memory on whether the patient is taking any medications. The patient is taking oral contraceptive pills. Now, as her current physician, I have the option to leave this prescription as is or cancel it. If I want to cancel the order, I'd simply click on the order and select yes or no to the prompt. For now, I'll leave this order as is. Next.
So I just wanted to introduce the primum for step 3 CCS. The clinical skills, your clinical judgment, everything is being judged. As I told you earlier, now if you are implementing next for the clinical decision making and clinical diagnosis, India need to create this whole system. Now, as regard the step 1 or step 2 is concerned, so this is step, you can go to the website and you can see all those sample items. So this step 1 is on basic sciences. And then it gives you all format. Now, why I'm showing all this is we need to be perfect while you are using scenario-based question papers. We have to give, say examples, and then go the laboratory values, the reference range, what exactly we are going to do, and then I'm showing you some of those sample questions. Now the image is there. I think this gives a lot of training, and image, questions, everything is there. It's about pathology, all microscopy, histology, everything is there. So I think this is about step 1. If you go to step 2, you can see those videos and the patient notes, and similar thing would be there. So this is about step 2, question paper, which is gone into detail. So I used the step 2 paper, and I think this is very rich and it can be used for training. And same thing, it gives you a very nice introduction for a single item questions, single questions, your training, and sequential questions. I think I only show these sequential questions in our format, and obviously same thing, it gives laboratory values, which are normal, reference range, and then it gives you all the sample questions. So these are X-rays, images. So this is about step 2. This is about step 3. Step 1. Now the USMLE website is rich in training how to construct a scenario-based questions, and all of them, they contain scenario-based questions. So even step 1, step 2, where the basic sciences is concerned, they are all questions on scenario-based. So I'm just trying to suggest that the USMLE applies same thing. If you go to MRCP UK, the same samples are seen, and I think all scenarios are clinical. Even Australian, Canada. So all Western advanced countries are using the clinical or scenario-based questions for evaluating. So it is high time that we use and we improve the quality of our MCQs in such a way that the clinical decision making, creativity, judgment, or all these faculties which are required to create a better doctor, to improve the quality of healthcare that we offer as an Indian medical graduate. So medical education has to identify and address to these needs and improve the quality of our MCQs instead of just condemning them, because all examination analysis are very good. We need to identify exactly the domain where it can be better used. But I think because world is going fast, India need to follow. And in case we want to offer a clinical evaluation of our students to the Western standards, because WFME standards will come in 2021, and it is high time that we also change our evaluation, maybe MCQ or whatever, with a scenario-based question paper. Thank you. I thank Dr. Sanjay Bedi for inviting me here, and I thank all of you for listening carefully. And let us hope we make evaluation better. Thank you.
Any questions, anyone? Please raise your hands. Yes, Dr. Deepti Shastri, please unmute yourself.
Good evening, sir.
Good evening. Thank you.
Thank you so much, sir, for lucidly explaining diverse ways in which clinical scenarios can be used for constructing MCQs. It was really a great learning experience from you, sir. Thank you so much, sir. My query is not directly related to MCQs as such, but I didn't want to miss the opportunity of asking you, sir, your opinion. Now that the MCI has said that each paper will be of 100 marks, theory paper, what, in your opinion, would be the question paper pattern, sir? Since it is competency based, not only MCQs, even essay questions could be scenario based. What is your opinion, sir?
Actually, we need to have all question papers, even long questions, short questions, on scenario based. Because SAQ could be nicely created with scenario based. Because what happens, instead of asking, what is management of an, say, hypertensive, say, retinopathy or hypertensive management? Instead, you describe, give details, give all findings, and then ask them, as the student, to find out how to manage. Or maybe giving a stem as big as MCQ, but then instead of asking, giving the items or distractors, ask them detail. How will you manage this? So that the student first has to go into the stem to identify and diagnose, give a differential diagnosis, what investigation being done, and then it applies everything, decision making, and then he knows how to manage. So I think even long questions, short questions, all questions could be based on a real patient scenario.
Thank you, sir.
Question?
Yes, sir. Thank you, sir. Can I ask one more question, sir?
Of course, of course.
Sir, do you think 15 marks for an essay is all right, or should we make it to just 10 marks, sir, for essay?
Actually, it's a sort of a policy decision. If you see the DNB questions, they have 10 questions of 10 marks. Nothing like short question or long question. But then all of them, they are descriptive. Now, what is required is enabling our system to see that it could be done automatically. So, the next level of examination, which we can use the technology, is what is called as a pattern recognition. So, if you have a clinical scenario given and all those questions, answers are there, we need to find out. Now, obviously, it requires an handwriting software, and then you need to find out which words are used and what is the pattern. I think Sanjay might answer it better, but this is a feature of examination. One of the long questions, you can examine on what's called the pattern recognition. Then there can be some words which are essential, and we have a lot of technology going on. It's called annotation. So having an annotation technology and pattern recognition, all those things could be used and identified.
Yes, that helps.
Thank you,
Sanjay,
sir.
you want to add something because this is your area.
I mean, in fact, if anybody of you has attended some Coursera courses, I mean, there they use all these technologies, and there is face recognition and a lot of the speed at the way you use. I mean, they are basically artificial intelligence is little bit incorporated. There is a site ihuman.org, ihuman.com. So in that they have got virtual patients also in which all these technologies are used. Dr. Shantanu Tripathi, you may like to ask a question.
Uh, uh, I just wanted to thank you, Dr. Jamkar. It was great listening to you. And I heard you. Yeah, of course. And I heard you in Kolkata a few years back. You came in that Vice Chancellor's conclave here.
Yeah.
So I no, yeah. So I like particularly the example of that malaria and that Plasmodium falciparum life cycle that the doctor is trying to explain by using a diagram. Apart from everything else, this question also sends on the message covertly that the counseling or the time that the doctor spends in explaining things to a patient, although that may not be the primary object of this evaluation, but then by this framing this kind of question, so in a lateral manner, you can also send home this message that learner should also get exposed to the importance of the doctor-patient communication and spending time with the patient in explaining things. So I thought that let me also, it was tempting to mention that. Thank you very much.
Thank you.
Any more hands? I don't see any more hands, sir. Anyone would like to ask a question or just a comment or say thank you to Dr. Jamkar? Dr. Chauhan, Viral Chauhan, yes. Yes. Dr. Viral Chauhan, you can speak. Okay. He has written it on the chat. Thank you, sir, for a very good insight.
I can't see that.
There's a chat button around it there. On the chat, he has written. You can also write on the WhatsApp group.
Okay. Do we have WhatsApp group of our whole thing?
Yes, sir.
And am I a member?
Yes, sir.
Okay. Because I require a feedback.
Yes.
Because we need to improve.
Yes.
Because this entirely new thing.
Yes, sir.
And where this has been already applied in Western societies.
Yes.
But I think the students who are appearing for USMLE, they might be doing better.
Yes.
They don't know how to construct those questions.
Yes. In the next 15 days, I think all of you will be, I will be giving you assignments, and you will be all actually making these, what we have learned in last 1 month or 2 months. You will all be making the, doing the actual assignments. Some of you have already submitted, but now more will be needed. We will be making a question bank of, in which each one of you will be contributing about 10 questions for each specialty. You can even join multiple specialties for making an integrated questions.
I think this is a good idea. Every professor should create 10 scenario-based questions.
Yes, sir.
Is it okay?
And
even if that's why I introduced whole concept that even basic sciences should be scenario-based.
yes, sir.
So everybody should create at least 10 questions, and then as a group we will evaluate, because what is required is creating those distractors.
Yes, sir.
And creating a clinical distractor is indeed an intellectual function.
Yes, sir.
Because if you see all those USMLE distractors, they are so nicely made.
Yes, sir.
So we need to train. That is because clinical scenes are available. You have real patients already there.
Yes, sir.
And what is required is because patients are complex, they may not come to single thing. So we need to suitably remove unnecessary things pertaining to other complications or other addition, and make that stem perfect by adding something which is not there in patient, but to make the direction towards suitable diagnosis or treatment. Okay, is that all?
Yes, sir. Thank you, sir. Thank you very much on behalf of the group. It was really.
I will take 1 hour.
Yes. I don't. 1 hour passed just without knowing the time. And there is one more announcement. Sir will be taking a free webinar on self-directed learning on 24th of this month. I'll be announcing it on MEU India.
Okay.
Yes. Okay.